The following podcast is part of a certified educational activity titled Rethinking Pulmonary Fibrosis, from fine-tuning diagnosis to illuminating novel pathways for emerging treatment strategies. Access the entire activity and complete the post-test at peerview.com/TCC860. Downloadable slides and practice aids are also available.
Hello and welcome to this educational activity on rethinking pulmonary fibrosis, from fine-tuning diagnosis to illuminating novel pathways for emerging treatment strategies. I'm Fernando Martinez. I'm at the University of Massachusetts Chan Medical School, and with me today is a friend and collaborator, Toby Meyer. Toby, welcome.
Thanks, Fernando.
We have a series of things that we want to try to accomplish in a relatively short time frame. So we're hoping to make this succinct so that you can get some key points. We're going to focus on a timely and accurate diagnosis of pulmonary fibrosis. This is achievable through a multidisciplinary application of current diagnostic criteria, goal being improving long-term outcomes. We're going to discuss emerging therapeutic options, including lysophosphatidic acid receptor antagonists. This represents an important treatment advance with a distinct mechanism of action, demonstrated clinical efficacy, and a manageable safety profile in pulmonary fibrosis. And then ultimately, the goal is to develop personalized treatment strategies that integrate guideline-directed therapies, novel and emerging agents, and how these can optimize disease control and slow progression in patients with pulmonary fibrosis. So that's our goal. I'm going to start off by just pointing out some of the current challenges in the space, some of the unmet needs, the gaps that are present. We're going to focus sort of on two broad components. The first is sort of the traditional idiopathic pulmonary fibrosis, which has been estimated to be between 6.8, 9 or so cases per 100,000. It's more common in men, more common as people get a little bit older. The rate of progression is very heterogeneous, can be unpredictable from patient to patient. There have been arguments that there are three broad categories of how people progress: very rapidly, slowly, or in steps. And then for a long time, the argument had been that the median survival was around 3 to 5 years. I think, Toby, you and I probably suspect that that's not accurate in the current space, particularly in people who are taking antifibrotic therapy. So it's a tough disease that really requires an interdisciplinary approach to care. The second component that's occurred in our field that has evolved is that we're not any longer just focusing on idiopathic pulmonary fibrosis, but now we have the concept of progressive pulmonary fibrosis, which can develop, that picture of progression can develop at about a third. There's an estimate on the right by various disorders how frequently it's expected to occur. And it's characterized by many of the same things we've seen in patients with IPF. That's progression radiologically, symptomatically, physiologically. And I'll show you a little bit later that it has significant implications in patients' outcomes. So it's not only just now IPF, but it's also the concept that in many other disorders, there can be a progressive phenotype that kind of looks like IPF. And Toby will take you through some of the therapeutic approaches. So it's important to understand both of those concepts, because that is now where the field of fibrotic lung disease is at, and we're progressing. There are, however, a whole series of gaps that are clearly present in the care of fibrosing ILDs, particularly if you look at that broader picture of not just IPF. And that includes that there are just well-described diagnostic delays, anywhere between 8, 9, 10 months or so. And it is not uncommon to see misdiagnosis. And that's part of the delay, COPD has, but just common things not being the obvious diagnosis. And that creates this long-term delay. There is acceptance that imaging and physiology are sort of key components of the evaluation process. I'll show you that in a second. And they're kind of underused. And then lastly, even though we have very effective antifibrotic therapy, Toby will describe that, they don't get used that often. And so there are a series of these gaps. That's part of the reason Toby and I do these programs, to be able to see if we can aid in minimizing some of these components in our patients. So as we continue with that thought, there are antifibrotics that have been approved. Nintedanib and pirfenidone can slow disease progression. There's a new one that's been approved as well. Toby will mention that. Nintedanib is the only one currently that's approved for the treatment of PPF. And that's based on the results of this inbuilt trial. Again, Toby will show that. So in the IPF space, we have multiple agents. In the PPF space, up until now for antifibrotics, we've had nintedanib. Unfortunately, the prior drugs, particularly nintedanib and pirfenidone, are tough to take. They just have a lot of adverse tolerability profile challenges. They've been hard for patients to really take long term. We've not up until now had a sense as to whether there was synergy between different therapies that has created this underlying sense that our therapeutic options have been limited and we need to do better things. Again, Toby is going to give you more of that detail as he presents in the latter half of this presentation. So with that in mind, sort of with the understanding that I want you to understand the concept of idiopathic pulmonary fibrosis, bad progressive disease, in a fraction of individuals with other disorders, mostly systemic disorders, they can be a progressive phenotype. How do we now, given those complexities, try to decide on the optimal diagnostic approach and how we're going to revise our concepts regarding optimizing therapy? So I'm going to show you a couple of patients, and I want you to have some key components for these patients because I think it relates to this issue of diagnostic delay in part. So the first is this 68-year-old gentleman who hasn't smoked, but has for the last 12 months had a sensation of a dry cough and breathlessness. Tip-off symptoms in an older person that you've got to clearly understand that fibrosing lung disease can be present. He's been diagnosed with other disorders, and he's been on inhaled therapies. There you go. That's the common scenario. Still slowly progressing. He's got underlying comorbid conditions, but mostly hypertension and reflux. But it's this concept that he's come back to you several times with cough and a sensation of shortness of breath that really should trigger in your mind something's up here. And so when you listen to the guy, you see that he may have a little bit of subtle clubbing, but more importantly, he's got basal arousal. That should trigger in your mind additional diagnostic efforts. And the key ones are trying to exclude systemic disease. And in his case, there were no identifiable autoimmune markers. I'll come back to that in a second. And you order a high-resolution CT scan, and there are classic findings in this 68-year-old gentleman where he has reticulation, he's got clear traction bronchiectasis, honeycombing. This is a pattern that we'll consider diagnostic for usual interstitial pneumonia. You obtain pulmonary function testing, and he's got restriction, and I'll say he's got a low diffusing capacity as well. So now, based on this clinical scenario, an older person, progressive symptoms, restrictive physiology, and that CT scan, in the absence of any other disease, you've got a diagnosis of idiopathic pulmonary fibrosis. And I'll show you how the current therapeutic guidelines and the clinical guidance that include diagnostic guidelines would have you approach this patient, because that's what you've done in this slide. This is a document that was produced by many of us that have been working in this field for a long time. And it sort of provides a framework for the evaluation process of a person that you suspect of having idiopathic pulmonary fibrosis. So this was really an IPF-focused initial diagnostic algorithm. And the first thing you see at the top is there anything else that's causing this? This is where we'll come up in the next series of slides. If the answer is yes, this person clearly has a systemic autoimmune disorder, then yeah, you've got something that's not idiopathic. You got an altered diagnosis. Go down that pathway. If the answer is no, there's nothing else obvious that I've seen in my initial evaluation of this patient while they're sitting in my office or clinic, then there is a central role for a CT scan. And if the CT scan shows that pattern of usual interstitial pneumonia, like the last person, Dan, then you got a diagnosis of IPF. If it's not a classic CT scan, or if it's indeterminate or suggests something else, then the most recent iteration of this multidisciplinary guideline introduced this idea of the MDD, which is a multidisciplinary diagnostic process, and actually something we developed at the University of Michigan 20 years ago, based on tumor conferences, Toby. That's how the whole thing came around. And that's sort of become now a standard for the diagnostic process. You know, you have an interdisciplinary team of pulmonary radiologists, pathologists, now rheumatologists who sit there and discuss these cases. And to be honest with you, in the post-pandemic era, I don't know about you, Toby, but all of this now is done remotely. We used to meet in person, chat about these things. Now it's all done through a remote process. And so it actually allows a broader group of individuals with multiple expertises to actually join these discussions, including primary care clinicians. And so that's now become sort of the standard approach that we've used to ensure a diagnosis in this particular slide, and for this last particular case, Dan, in the setting of idiopathic pulmonary fibrosis. So it is an interdisciplinary approach to collating a series of data, clinical, serological, imaging, and potentially in some cases pathological, to come up with a diagnosis. All right, so that is sort of a typical IPF scenario. As the field of fibrosing lung disease has expanded, you've got Renee, who's a 58-year-old woman who has a history of systemic sclerosis diagnosed several years ago. She's been known to have Raynaud's for a long time. She's got mild sclerodactyly. The skin has thickened a bit. But the key symptoms in her case, from the point of view of this presentation, is the fact that she's been experiencing similar symptoms to Dan. Got a cough, breathlessness has been gradually getting worse despite being treated in standard fashion with immunomodulatory therapy. Toby will talk about that a little bit later on. And so that should trigger in your mind, okay, I've got a person that has systemic autoimmune disease, but has respiratory symptoms. And when you listen to her chest exam, guess what? Same RALs are present. And so in this individual, the diagnostic process, to a large extent, is similar. You've got CT scan on the right-hand side, which in this case shows reticulation, traction bronchiectasis, no clear honeycombing, and there's a suggestion of mild ground glass opacification. This is not the classic usual interstitial pneumonia pattern, but in the setting of this individual with systemic sclerosis, there are clear features on that CT scan that there's a fibrosing lung disease. On the left-hand side, you see physiological studies. Similar to Dan, IPF patient, there's restriction, the low FVC, low TLC, and a diffusing capacity abnormality. So now in this particular individual with an underlying systemic autoimmune disorder, there's evidence of a fibrosing disease and progressive symptoms. So as you contemplate this case, you've got now an individual that has a clear-cut underlying autoimmune disorder. She's got a positive anti-centromere antibody. She has features with the clinical scenario, particularly the progressive symptoms and the physiology, that should suggest in your mind, is this one of those components of individuals that was on an earlier slide that has evidence of progression clinically and by imaging, such that I now need to consider what I'm doing therapeutically. And I mentioned earlier that in the IPF diagnostic algorithms that we had developed over time, there was this multidisciplinary discussion, this MDD box that you saw on an earlier slide. That originally was a box that was to constitute an interdisciplinary team that was principally the pulmonologist, the radiologist, in some cases the thoracic surgeon if you were considering doing a surgical biopsy. Now it's IP people in case you're doing a bronchoscopic procedure. And it has been expanded now in many cases, and Toby, I suspect this is what you guys do at your place, where the rheumatologists almost routinely participate in these conferences because the diagnostic discussion is now a bit more complex. In a good way, because that means you have more therapeutic options, but it has raised some additional complexity. And so when we have these MDDs now, with the setting of including systemic autoimmune disorders, there are a whole series of these. You saw them on an earlier slide: systemic sclerosis, like Renee, connective tissue disease, RA, inflammatory myopathy, Sjogren's. They're not the only ones, but there are a series of these systemic disorders where we now understand that a proportion of those individuals, unclear exactly what that proportion is, but a proportion of those individuals can progress with their fibrotic lung disease and fit this phenotype of progressive pulmonary fibrosis. And you'll see a little bit later on that their outcomes are almost as bad. And so now we've got a bit more complexity because we have idiopathic pulmonary fibrosis, which is, it's a lung disorder that has usual interstitial pneumonia. It is the prototypical progressive disorder. It doesn't respond to immunosuppression. In fact, we demonstrated that immunosuppression kills those patients. Whereas on the left-hand side, you now have these patients with systemic disorders that are multi-system components that have a whole series of complex autoantibodies, that the appearance in the lung is a little bit different, but can progress. Some of them respond to immunosuppression. And now the question becomes, how do we optimize the management of these two broad categories of fibrosing disorders, particularly as they're progressing? In the systemic autoimmune space, that there is also additional complexity in that the pattern of abnormality in the lung may vary. If you looked at that right-hand side CT, the usual interstitial pneumonia pattern, basilar predominant, honeycomb, reticulation, traction bronchiectasis. If there's no systemic disease, that you'll call that IPF. But that can also be seen in the setting of rheumatoid arthritis. The left-hand side is sort of more the pattern that you would expect in a person like Renee. That is the non-specific interstitial pneumonia pattern where there's more ground glass, there's reticulation, but there's not distinct honeycombing. And that pattern can be seen across a series of systemic autoimmune disease. So you can imagine that these multidisciplinary discussions now are in fact more complex because it's not just IPF anymore. Now it's IPF and systemic disorders with fibrosing lung disease, varying pictures on CT, and a proportion of these individuals may have very similar levels of progression. All of those concepts are concepts that you're now taking into account in your own mind as you're trying to decide, how am I going to optimize the care of these patients? The major change that we've now seen, and this is actually from Vincent Cotin, who's a close collaborator of Toby and ours from Lyon, who this is very similar to what I showed you earlier from that ATS, ERS, JRS, ALOT multidisciplinary guideline. But the difference that Vincent has done here, which I think all of us have understood now, is that this MDD now has expanded beyond just the diagnostic paradigm, but is also now starting to encompass how we monitor the patients over time, particularly patients that have systemic autoimmune disorders, so that we can all come to a consensus. This patient with a systemic autoimmune disease is progressing, and the therapeutic approach is now more complex and has to incorporate what Toby will show you in a few minutes. So I like this modification of the MDD because it expands its role beyond just diagnostic pathways, but also into definitions of progression and helping the interdisciplinary team guide therapeutic options. And so when I keep talking about this interdisciplinary team, particularly as they relate to the management of a patient and how they're incorporated into these discussions, there are actually a whole series of things that take into account. And so that's why the composition of these teams has expanded. Toby, I suspect that's what you've seen at your institution, is that these teams have become broader and broader. And it's not just you and I, Toby, now doing this with a radiologist, but now it incorporates the radiologist to aid us with progression. It incorporates APPs. So our ILD program is really run by a nurse practitioner who has tremendous expertise in this area. In some places, it's the PA. Physical therapists are involved. Rheumatologists are very actively engaged because now the team has multiple different roles. We've all got to educate the patient in this complex landscape. We're all monitoring patients, particularly those for progression and where we may have to make changes therapeutically. There are multiple pharmacotherapies and non-pharmacotherapies that are approaches to symptom management and palliation of those symptoms. And then there's this whole concept of how to incorporate a broader group of individuals that are going to help manage that patient over time to really optimize what occurs in that individual patient. So for some of us that are much older, Toby, that have been doing this for 30, 35 years, this is a much more complex series of discussions now, but that's actually a good thing, guys. The one key thing to understand, and this really is an important slide, is that we know that IPF is bad. If you look at that left-hand side, and you look at the bottom curve, that is the survival of IPF. But in patients who have progression, patients with systemic autoimmune disorders, so that's a lot of those multicolored curves on the left-hand side, when they're demonstrating evidence of progression, they have survival characteristics that start simulating IPF. That's sort of seen on the right-hand side. If you've got a person that has a systemic autoimmune disorder whose disease is stable, they do a little bit better. IPF does bad, but in the setting of progression, that right-hand panel shows that middle curve. These patients who progress, even with an underlying systemic autoimmune disorder, have a disease that is deadly. And so it is really important for all of us to conceptualize the diagnostic process, early diagnosis, appropriate diagnosis, and close monitoring to define progression, because therapeutically that is going to it's going to be important. Some of us, Toby, you and I, have been involved in some of these guideline recommendations. So this is one of these that actually you saw a slide from that earlier. That was a very broad ATS, ERS, JRS, ALOT guideline. One of the things that we included in there was the concept of how to define progression in a non-IPF patient, a predominantly systemic autoimmune disease, although organizing pneumonia and HP, all of those can be present in that broad bucket. And so we sort of arbitrarily came up with this. This wasn't based on this massive database that was, God came down and told us this. This is a group of us thinking, well, you know what, if a patient is more symptomatic and their pulmonary physiology is worsening and there's evidence of that fibrosing changes are progressing in CT, kind of looks like progressive fibrosis. And so that has become the standard. It continues to be modified. The thresholds are being modified. The time periods have been modified. But the underlying concept, I think, remains the same. And that is, as you're evaluating patients, particularly patients who do not have IPF, but have one of these systemic disorders, that it's important to monitor symptoms over time, pulmonary physiology over time, and imaging, because you're going to use those in combination as you're sitting in these MDDs, and you're going to define a patient as having progressive fibrosing disease or not. And that has mortality implications, as I showed you on the last slide, and it's going to alter what you do therapeutically. So that now starts to introduce the concept of what are the potential therapeutic options that we have now. I don't have enough time here to describe all of the potential biological pathways that are associated with inflammatory disease and a profibrotic state. Toby, you and I don't have 3 or 4 hours here to do this. We know nintedanib and pirfenidone have relatively distinct pathways. Those are approved for IPF. Nintedanib approved in the U.S. for progressive pulmonary fibrosis. There are a series of immunomodulators. Toci is on the top right-hand side. Toby will briefly mention that. And then the newest player in the game is nerandomilast, which has just been approved in the U.S. for IPF. It's a selective PDE4 inhibitor. It's got immunomodulatory antifibrotic properties. So part of the reason I show you the slide is that it is no longer just one treatment. It is now multiple potential options that you have in individual patients. And the field is going to become even more interesting this next year, because there's an entire not new pathway, but a new therapeutic approach which targets this particular pathway. So ATX, autotaxin, is an enzyme that is involved in lipid metabolism. It converts LPC, which is lipophosphatidyl, just going back to your medical school or training days, trying to say that quickly, and generates LPA, lipophosphatidic acid, which binds through a series of these signaling pathways, the receptors. The key ones are probably 1 and 2, you see them in the bottom left-hand side. And these are really key mediators of a whole series of events that are associated with an inflammatory and profibrotic state. And in fact, there's been really a really good sense that this particular signaling pathway is associated with a whole series of cellular events that ultimately are associated with a profibrotic state and a pro-inflammatory state. And as a result, they've been implicated in IPF, systemic autoimmune disorders, particularly those that have progressive features. And part of the reason that we bring this up now is that there is a potentially viable therapeutic option when you now are contemplating the complexity of the pathways that you have to treat. How are you going to incorporate this particular concept? So I leave the simplest part to you, Toby, which is describing the complexity of these therapies and how they can be used to improve a patient outcome.
Thanks, Fernando. And that's a great overview of a lot of the challenges we face in clinical practice when presented with a new patient. And I'm now going to try and as succinctly discuss how we might think about treatments, particularly some of the innovative therapies coming down the line in the very near future. And so as has been alluded to already, our approach to treating interstitial lung disease is certainly at diagnosis dictated by the diagnosis that we make. I think there's a danger with the concept of progressive pulmonary fibrosis that we think we should lump everything all together at outset. That's not strictly true. I think we still need to rely on a precise diagnosis obtained at an MDT to guide our initial therapy, but then as we observe disease behavior in response to treatment, there becomes an overlap in the way we think about treating these conditions. But certainly with IPF, we know from the Panther study published now back in 2012 that showed high doses of corticosteroids and azathioprine were harmful in patients in IPF. We know that in IPF, really, we want to avoid aggressive immunomodulatory therapy and instead rely primarily on antifibrotic treatment as our first-line pharmacotherapy for patients with this deadly disease. For other forms of interstitial lung disease, I think our initial treatment strategy is more nuanced. It's certainly heavily dependent on diagnosis. With the systemic autoimmune rheumatic diseases, very often our initial treatment is going to be immunomodulatory, focused on the underlying immune mechanisms that we believe drive the development of the interstitial lung disease. In conditions like hypersensitivity pneumonitis, we're obviously going to think about removing antigen. And again, if there's evidence of active inflammation as well as fibrosis, thinking about the use of corticosteroids and other immunomodulatory therapies. But once these conditions show evidence of progression of fibrosis, as Fernando has nicely shown, the prognosis begins to overlap with idiopathic pulmonary fibrosis. The disease mechanisms that drive that progression overlap with idiopathic pulmonary fibrosis. And as we've seen with trials like INBUILD, where nintedanib was used as an antifibrotic drug in these patients with progressive pulmonary fibrosis, we know that targeting fibrotic pathways has an important role in changing disease trajectories for these patients. So in IPF, we have primarily an antifibrotic approach. In other ILDs, we have a more nuanced approach that may combine or may begin with immunomodulatory therapy and move over time to antifibrotic therapy. And in some cases, we're going to combine both strategies in the same individual. And again, as Fernando has alluded to, we now have a number of treatments approved for the treatment of fibrosing interstitial lung disease. And so since 2014 in the US, we've had both nintedanib and pirfenidone approved as therapies for idiopathic pulmonary fibrosis. More recently, nintedanib has also been approved for treating scleroderma-associated ILD and for treating progressive pulmonary fibrosis. As I'm sure everyone is aware, we don't have a full understanding of how either nintedanib or pirfenidone truly works. Nintedanib is a broad-acting tyrosine kinase inhibitor, works on a number of growth factor receptors. It's probably the fact that it interacts with lots of different growth factors that is important in its beneficial effect in treating fibrosis. Pirfenidone, another small molecule, we even less well understand how that works, but we do know that it interacts with pathways like the TGF-beta pathway and the TNF-alpha pathway. And we know that both drugs slow FVC progression, but they do so at the cost of side effects, primarily GI upset. And again, as everyone will know from their own clinical practice, using nintedanib and pirfenidone can often be quite challenging, that patients have to make significant lifestyle alterations to be able to tolerate drugs in the longer term. And then more recently, we've seen tocilizumab approved specifically for scleroderma-associated ILD. The clinical trials showed benefit in patients with diffuse cutaneous systemic sclerosis and evidence of active inflammation. And so that is more of a niche role for tocilizumab. And then very recently, we've seen the approval of nerandomilast, which is a PDE4B inhibitor as a treatment for idiopathic pulmonary fibrosis. And our expectation is that it will also be approved in the very near future for progressive pulmonary fibrosis. For those of you who like to read guidelines, again, Fernando has already highlighted this guideline. This was the ATS, ERS, JRS, ALAT guideline on IPF and PPF published in 2022, as well as covering off identification and diagnosis. There is a section on management of disease. Just for the purpose of this talk, if we focus on that second box to the left-hand side, you can see there the list of therapeutic options to consider for patients with IPF, which is now the 3 drugs: nintedanib, pirfenidone, nerandomilast. And I won't go into detail on the sort of non-pharmacological therapies or the management of comorbidities, but of course, that is also a very important component of what we do in managing our patients. And then more recently, we've seen the publication of the American College of Rheumatology and Chest guidelines on the management of SARD-ILD. For those of you for whom this is a new acronym, SARD-ILD is classically what we pulmonologists have referred to as CTD-ILD, but technically rheumatoid arthritis does not fall under the umbrella of CTD, and so SARD-ILD, systemic autoimmune rheumatic disease, is a slightly broader umbrella that now encompasses both rheumatoid arthritis and the classic connective tissue diseases like scleroderma, myositis, and mixed connective tissue disease. This figure is the treatment figure that has been taken out of that document. As you can see, we have more options to consider in patients with SARD-ILD. I think that the challenge in interpreting the guidelines is that we have a shopping list of potential therapies. The document is less prescriptive on exactly which ones we choose in which situation. And so as clinicians, as MDT meetings, we have a choice to make when it comes to thinking both about initial therapy for patients with SARD-ILD, but also therapy for patients who are progressing despite initial treatment. And I'm not going to go into each bullet point in detail, but we will cover off some of this in the next few slides. And so to come back to the emerging data, as I've already alluded to, nerandomilast, which is a PDE4B inhibitor, so really the first targeted therapy in IPF, the first therapy that is going after a specific pathway, has very recently been approved in the US as a treatment for IPF. And that has been on the basis of the FIBRONEER-IPF trials, the data from which is shown here. The one thing that is different about the way the FIBRONEER trial was done compared to the pirfenidone and nintedanib trials a decade ago is that in this study, patients were allowed to be on background antifibrotic therapy. So about 80% of patients were taking either nintedanib or pirfenidone, and only 20% of patients were taking nerandomilast as monotherapy. As you can see from this figure, the placebo group saw a reasonably rapid rate of decline with an FVC loss approaching 180 mils over 52 weeks. And nerandomilast at 2 doses, 9 milligrams and 18 milligrams, was effective at slowing that rate of FVC decline over the duration of the study. And then we have the FIBRONEER-ILD study. So this is an identical study to the IPF trial, except that it was conducted in patients with progressive pulmonary fibrosis. The definition of progression that was used for this is slightly different to the ones from the guidelines that Fernando described for us, but to a large part it overlaps, and it was the same criteria that we used in the INBUILD study with nintedanib. Patients had to show decline either in FVC alone of greater than 10% over the preceding 2 years, or a combination of FVC decline between 5 and 10% over 2 years, plus worsening in symptoms or plus worsening in radiological appearances, or they could just have the combination of worsening symptoms and worsening radiology. And again, as you can see, the drug was effective. Importantly, this group of patients show an appreciable rate of FVC decline over the 52 weeks of study. The rate of decline is almost indistinguishable from IPF. Again, just reiterating that point that Fernando made. This is a poor prognosis condition. Once patients have shown evidence of progression, their disease almost inevitably gets worse in the same way that we see with IPF. And again, you can see that both doses of nerandomilast were effective in slowing FVC decline. This is the safety data. So with nerandomilast, we are seeing some GI disturbance. We're seeing some diarrhea, but really not to the extent that we've seen with nintedanib or pirfenidone in the past. The one set of patients in whom we saw the most diarrhea were those who were already taking nintedanib. So used in combination with nintedanib, there were patients who were reporting diarrhea more frequently. And so the safety of nerandomilast in the ILD population really mirrored exactly what we saw in the IPF population as well. And so that brings me on to admilparant. You've heard from Fernando why the LPA receptor pathway is important in the pathogenesis of fibrosis. And admilparant is a specific antagonist of the LPA receptor 1. So it should influence the development of fibrosis driven by the LPA pathway. And so admilparant has already been tested in a phase 2 trial. And this slide gives the design of that study. So in this study, patients were randomized 1:1 to receive either admilparant at 30 milligrams twice a day, 60 milligrams twice a day, or matched placebo. As you can see, 240 patients were randomized into the study. And the primary endpoint was change in FVC at 26 weeks. And then beyond that point, patients were given the opportunity to go into an open label study. And that included the placebo patients who were then separately randomized to one of the 2 admilparant doses with long-term outcome then assessed in that open label component. And then finally, as you can see at the bottom of the slide, patients were allowed to be on background antifibrotic therapy. So admilparant was being used in addition to either nintedanib or pirfenidone, or the possibility that patients were on no background treatment at all. And these are the data from the study. So in the IPF patients, you can see that the highest dose of admilparant, which is the sort of darker blue bar towards the right-hand side of both graphs, was effective at slowing the rate of FVC decline over 26 weeks compared to placebo. The reason you've got 2 sets of bar graphs is because there were different approaches, statistical approaches taken to the analysis of the data, but both approaches resulted in the same outcome, demonstrating a positive effect of treatment with admilparant on FVC progression over time. As I've already alluded to, there was also a PPF component to this study. So this was run in parallel at the same centers. The study design, again, was to all intents and purposes identical, except that patients had to have progressive pulmonary fibrosis defined using the inbuild criteria. And these patients could be on either background antifibrotic therapy, or they could be on immunosuppressants such as mycophenolate mofetil. And again, admilparant was effective in slowing the rate of FVC decline over 26 weeks. Again, you can see the highest dose, the 60 milligrams twice a day dose in the darker blue color there. Again, the 2 statistical analysis techniques, but again, showing the same point that the higher dose of admilparant was very effective at slowing the rate of FVC decline over 26 weeks. And then another way of looking at this data, so a post hoc analysis that was performed, was to look at time to disease progression, so death, hospitalization, or time to 10% FVC decline. And you can see from both of these Kaplan-Meier plots that the left-hand one is in the IPF cohort, the right-hand one is in the PPF cohort. Admilparant was effective at slowing or delaying the time to disease progression in both sets of patients. And overall, admilparant was extremely well tolerated. With these sorts of composite adverse event tables, I always think the most important line to look at is the discontinuations due to treatment emergent adverse events, which is the fourth row down. And as you can see, the number of discontinuations in the active treatment group, particularly the highest dose of admilparant, was, if anything, less than what we saw in the placebo arm, which I always think is a good way of measuring how tolerable the treatment is overall, suggesting that admilparant is undoubtedly much better tolerated than pirfenidone and nintedanib in these patient groups. And so that positive phase 2 trial has led on to the design of parallel phase 3 studies in patients with idiopathic pulmonary fibrosis and in patients with progressive pulmonary fibrosis. This is the detail of the IPF study. This is very similar to what was done in FIBRONEER studies. The one difference being that because there appeared to be a dose response with admilparant in the phase 2 trials, a decision was taken to actually go in with an even higher dose in the phase 3 study. So the phase 2 study was done with 30 milligrams and 60 milligrams. The phase 3 study is actually being done with 60 milligrams and 120 milligrams to see if even greater efficacy can be achieved with the higher dose. Because of that higher dose, an initial safety cohort of 60 patients has been built into the trial. So to start with, the first 60 patients went into what was essentially a safety study. And once those patients successfully passed through that, the bigger phase 3 study started enrolling. And that study really mirrors the FIBRONEER-IPF study design, which is to say patients were randomized 1:1:1 to the 3 doses and will be followed through to FVC as the primary endpoint at week 52. And the PPF study really follows the identical design, except that it's recruiting PPF patients, not IPF patients. And so having covered off some of the sort of exciting developments we've seen in our space in the last 2 or 3 years, it's worth just reflecting on how that's likely to change things in terms of treatment for our patients moving forward. As we've alluded to, this new generation of antifibrotic therapies is now going to be much more targeted than existing therapies. We have nerandomilast, which is targeting the PDE4 pathway. We have admilparant, which is targeting the LPA1 receptor pathway. And so we can imagine a future where we start to build combinations of therapy that target specific pathways of disease and where we can choose from a list of drugs with complementary treatment effects. Also, as I've talked you through, we've seen now that these studies are starting to involve combination therapy. And so I think an exciting challenge for us in coming years is to work out how these treatments work together, how it is we use combinations of treatment when it is that we think about introducing combinations versus monotherapy. And of course, the more successful trials that we have, the more options we have to initiate specific treatments in our patients. And so again, we will be in the challenging but good challenge to have situation of needing to select between different therapies and guide our patients with regards best choice for them as initial treatment of their fibrotic lung disease.
One quick thing regarding that. So can you imagine, Toby, because you and I are now in the process of trying to design a study to guide us on how to combine therapies in individual patients. Can you believe that's where we are right now in the fibrosis space, where we're actually wondering about how to combine therapies? What a major advance we've made.
Yeah, I know. Like I say, I think it's an exciting problem. And you've already told us you've been doing this for 35 years. I've almost been doing it for 25 years. Both of us well remember a period of time where we had no treatment options for our patients. And so to be in a position where, we have to figure out how to use combinations, how we have to figure out which drugs to choose in which order, It's clearly going to be challenging, but it really is a very important and exciting challenge for us to have, and is a much better place to be than we were 15 years ago. I think a lot for us to learn in the near future. So now we can return to the cases that Fernando presented for us earlier. Fernando, you focused primarily on the diagnosis in your part of the presentation, but having now thought through the treatments, I think we can try and take what we've learned and see how we can integrate it into these cases. So Dan was the man with idiopathic pulmonary fibrosis. Historically, we would have considered treatment with pirfenidone or nintedanib, but we are soon to be in a position where we may well have pirfenidone, nintedanib, nerandomilast, admilparant. And I guess, Fernando, how would you address this in your MDT? What would be your thinking with regards treatment, and how might you be thinking about monotherapy versus combinations of treatment?
So as you mentioned, Toby, this is a good situation to have where we're actually trying to worry about which agent to choose. This is very different than what you and I have had to deal with in the past. And so I think there's no question that this person will need an antifibrotic. That raises the question of which antifibrotic. And we have no really good way right now, other than patient desire, tolerability issues, and what a payer will do in terms of allowing us to use these agents. And I think that the question for us in that respect, Toby, will be whether there will be features that will allow us to choose one agent versus another based on biological characteristics, not some payer saying you can use this one, you can use that one. Well, I'm sure that will come. And whether we will want to consider using combinations, because now we have data that combinations are effective, that they have good and bad, and how we will do that. That also has cost implications. And then I think over time, Toby, as we try to decide how we're going to alter therapies, none of us really know exactly how we're going to make those decisions, which is why I think you and I are trying to work out study designs right now to help guide those components. It is a good problem to have, but it is a challenge.
Yeah, I fully agree. I've long looked at the oncology field with a degree of envy at the way that they are able to personalized treatment for patients based on molecular features of disease. My dream for the future is that we will have ways of being able to personalize treatment for patients, that we will have much better ways of deciding about, upfront combination therapy. And if we are going for upfront combination therapy, which combination of treatments. But I think at least having options puts us much closer to that goal of genuinely preventing disease progression in patients with IPF, and hopefully restoring what might be considered a normal life expectancy for these individuals. Because again, as you and I know, although we've had treatments for the last decade, which has been super important, our patients are still dying ultimately of respiratory failure. So we really need these treatment advances if we are to shift the dial on outcome for patients with these diseases. And so our second case was Renee, the lady with scleroderma-associated ILD. And I guess, Fernando, the challenges that we've already articulated in IPF with choosing combinations are even greater in scleroderma ILD, where we have a much bigger portfolio of therapies to draw from. And I'd be interested to know how you think about this balance between immunomodulatory therapy and antifibrotic therapy in this sort of situation.
Yeah, one of the things that I took away from your presentation, I'll always learn something new from you, Toby, is how to emphasize the importance of an accurate, not even just an early diagnosis, but an accurate diagnosis, because there are so many additional therapeutic options. So as you know, for a person like Renee, there are several immunomodulatory agents that you would use, alone or in combination. So that just adds some complexity in terms of decision-making. I think based on the nintedanib studies, we have a pretty good sense that there is a role for antifibrotic therapy in the setting of progression, even when there's underlying immunomodulatory therapy, although, that's a whole separate study design complexity of these studies. And nintedanib has been all we've had. The problem is this is a particularly challenging drug for these patients to tolerate. And so I think that's why, at least I am, and I know you and I have talked about, we're hopeful that nerandomilast gets approved in this indication. I think it'll be better tolerated. And I hope that the admilparant study is positive and it has the same tolerability profile, because I think that will make things a little bit easier for us to have at least 2 antifibrotics that are probably better tolerated that may be able to favorably affect progression. And my sense has been, Toby, that these patients with systemic autoimmune rheumatic diseases are actually more complicated now to discuss than even the IPF patients, because of the complexity of the immunomodulatory regimens. And now when we have 2 or 3 antifibrotics, it's going to become challenging. But as you said, in a good way, because this is different than what we had before, and it should improve patient outcomes.
Yeah, I would fully agree with that. And I think, the advantage that we have in the SARD-ILD patients is often we can pick up the ILD at a very early stage, because these patients present with systemic symptoms fairly acutely. And unlike IPF, where we're often only picking up patients when they've got significant physiological impairment, in SARD-ILD, we're often seeing patients with initial trivial interstitial changes that progress over time. And my long-term dream would be that we genuinely prevent the development of interstitial lung disease in these individuals, that we do what the rheumatologists have done for rheumatoid arthritis, that we don't just try and protect patients from the symptoms, that we actually genuinely disease modify. And again, the more choices we have, the higher the likelihood that we can achieve that sort of outcome.
But Toby, this case, this Renee, and the second slide of her case also brings up something else that I need to plug, because you and I do clinical trials for a living. And so we would not have gotten to the stage without having all these clinical trials. So I think it's still important for all of us that are in this discussion, including all of the participants, to realize that there are ongoing clinical trials. And the more information and the more therapeutic options that we have, the more we'll be able to aid you in achieving your ultimate goal of prevention of disease.
Yes, fully agreed. That's a very good plug for trials. Without the generosity of our patients participating in them, without the hard work of our clinical trial staff, we wouldn't be where we are. But to answer all these questions about optimal combinations and modifying disease outcomes, you're absolutely right. More trials are needed, so we mustn't forget them. So I think that brings us to the end of the slides. Just to summarize what everyone has heard in the last 45 minutes, Fernando has told us about the importance of early and accurate diagnosis of fibrotic interstitial lung disease, and particularly the importance of the MDT meeting, which has grown over the years and now includes a whole range of colleagues, and most recently expanded to include our rheumatology friends. We've talked through the data for treating with anti-fibrotic drugs. We've talked you through the emerging therapies. Fernando gave you the background on why LPA is an important pathway in fibrosis. And I've shown you the emerging data with nerandomilast and now admilparant. And then we've briefly touched on the challenges that we're going to have in the future, choosing between a number of different therapeutic modalities and working out how to combine those in specific patients. So I think the future for our patients is much brighter than it was even 10 years ago. And I think between us all, we've got a lot of questions that we need to work out the answers for, but we're in an exciting place to be with regards to treatment of fibrotic interstitial lung disease. So that leads me to draw things to a close and simply to thank you, Fernando, for being such a great partner in this talk. And I look forward to many future discussions like this going forward.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported through an educational grant from Bristol Myers Squibb. To access all materials for this activity, visit peerview.com/TCC860.